called Emerging Global Leader Award. And this is an award that is given to low and middle income researchers who are interested in a research career path. And it does support a good chunk of, it does offer a good chunk of salary support. So if you're looking for a research career, I think this is a very, very good grant mechanism for you. It is a lot of work to put it together, but I think KNH department is now committed to supporting research, and you can get the support that you need. So if you Google the Fogart International Center and then Google Emerging Global Leader Award, you'll be able to see that funding mechanism there. Usually their deadlines are in November. They fund both AIDS and non-AIDS topics. So December 9 for AIDS, and then November 3rd for non-AIDS. So there's still time, still quite early in the year. Okay, I would just like to acknowledge my mentors and collaborators. So for this grant mechanism, you need mentors, and you need mentors both from the US and mentors from your country. And I would like to acknowledge the role that these mentors have really shaped in supporting me to get this grant, led by Dr. Irene Njunguna, who's my primary mentor, and Dr. Grace John Stewart, who's my secondary mentor, my secondary US-based mentor. And then Laura Oyengo, who was in the ministry at the time of application and who's really played a big role in shaping how the study looks now, and others in the team that have really sacrificed a lot of their time and energy to make this grant a reality. I also want to acknowledge the study team on the ground. This grant supports salary, but has very little funding for support. And so we have Florence and Calvin on the ground collecting data, Cyrus, Helen helping with qualitative data, and then Sylvia doing lots of administrative work. Again, these grants from NIH require a lot of administrative support that is really critical for the study. Okay, so I'll start with a brief introduction, and then I'll review the overall study aims and the study sites, and then I'll spend the bulk of the time looking at the study results, and particularly the results of the school survey that we recently completed. And then I'll end with next steps. So we know that there's consistent evidence that adolescents living with HIV are at high risk of poor clinical outcomes. However, we also know that thanks to optimized HIV treatment approaches, as well as programs to keep children and adolescents in schools in many sub-Saharan African countries, that many of these adolescents spend most of their time in schools. In sub-Saharan Africa, as a lot of you are aware, boarding secondary or high schools are common, and entry coincides with the middle adolescence period. We already know that there are school-related barriers such as adherence, school-related barriers to adherence such as stigma, challenges with medication use, challenges with attending clinic, and these are now common challenges among adolescents living with HIV. However, we also know that there's very little work that's been done to improve HIV outcomes in the school environment. So this work that we'll talk about was motivated by previous qualitative work we did from the ATTACH study. I believe a few months ago, Karen Buru presented the results of the ATTACH study that was looking at developing and testing a tool to support youth transition to adult care. And so we talked to youth about barriers to adherence in this study, and they highlighted the key themes that were challenges, and many of these were related to the school environment. They were around stigma, privacy using medication, challenges with clinic attendance, medication storage, and also school choice. And just to read a few of them, when we look at medication, one youth commented that the fact is that there is no really privacy of taking your drugs when you're in boarding school, which is a consistent challenge. And then around medication storage, one youth reflecting on the experience said that sometimes the school nurse leaves keys to her drawers with other students. And sometimes when you go to take your medication, you get that it's the prefect. So again, highlighting challenges with inadvertent disclosure and stigma. And I think one interesting one that we hadn't really thought about in a research setting, though we had heard about it anecdotally from people who have been working with adolescents living with HIV, was around school choice. And this adolescent said that the parents, referring to the parents, they refused to take me to boarding because my mother feared my peers would stigmatize me in school and I'll stop taking my medicine. So I feel parents should not restrict your life so much. So a lot of the work that I'll be talking about was really built around this this work. And around that time, this was an issue that the Ministry of Health was concerned about, and Dr. Laura Yengo was working at NASCOP at that time, spearheaded the development of guidelines to support HIV care in the school environment. These guidelines were published in 2009, and this was right before this work was funded. And as far as we know, they have not quite been implemented. I could be wrong, but the schools that we've gone to so far have told us that they have not been implemented. This guideline aims to equip school staff with HIV knowledge and skills to promote an unstigmatizing school environment. Specifically, they propose education, adherence support skills, psychosocial support systems, and community engagement. And I do want to just highlight some of the work that Dr. Kose and team, and I know Dr. Kose is on the call, are doing in Homa Bay that is quite aligned to this work. And many of these things are probably already implemented in some of the settings in Homa Bay. So the overall study design, this is a study design for TIMIZA. We had 3 broad goals. The first goal, and these were the activities planned for the first and the second year, was to understand current school practices, policies on HIV care, and then also to talk to caregiver and adolescents and see what their experience in school is, and look at school-related correlates of poor outcomes. And these are the activities that are currently ongoing, aim 1 and aim 2. We are currently at the middle of year 2. And then we plan to use the data that we collect in year 1 and year 2 to work with policymakers and other stakeholders in education and health to develop and pilot an intervention to support adolescents in the school environment. Again, this could be aligned to the guidelines that are already in existence, or could be around helping schools to implement the existing guidelines. And then in the future, yeah, I think we talked about that. In the future is a bigger study that's looking at school interventions. So today I'll share the results from the recently completed school survey, as I mentioned, and we have time at the end, a few things that we've learned so far from the qualitative work and from the youth surveys in aim 2, which is work that is still ongoing. Before we jump into the survey results, I just wanted to mention that the TIMIZA study sites were conveniently selected. I had mentioned that the funding for research is quite small. So we worked in the sites that were already had ongoing research activities that we could leverage existing resources. And so the sites are in 3 counties, Homa Bay with an adult HIV prevalence of about 20% and about 10,000 adolescents and 20,000 youth living with HIV. And then we have Nairobi with low adult prevalence, but almost similar number of adolescents and youth living with HIV. And then we have Kajiado with quite low HIV prevalence, a little lower. I think 3.9 is still high, but quite low compared to the other sites, and a much smaller population of adolescents living with HIV. This was estimates from 2017. So what we planned to do was to characterize school health services and school policies on HIV care. And the specific things we were looking at was staff training, policies on medication use and clinic attendance, and also stigma reduction activities available in the school. So we selected 100 public secondary schools. The plan was to select 100 public secondary schools. And to do this, we obtained a list of all secondary schools in the counties. And we specifically went for the public schools just because it's probably easier to implement policy at the public schools, and the differences are likely to be less compared to the private schools. And then we also stratified by boarding or day schools, so that we could get a good amount of information from both of them. So we obtained this list from the 3 counties, and when we started this work, I think as a healthcare worker, we don't really know how to get permission for school activities. And so this was something that we worried that we would have additional delays or additional layers of paperwork. But I must say that the county education offices were very supportive and were able to obtain all approvals at both county and sub-county level in record time. So Homa Bay had a list of about 329 public secondary schools. We did exclude some of the schools that some of the sub-counties, because we felt that with one staff, it would be really hard to access them. So we ended up with 329 public schools, Nairobi 84 and Kajiado 93. And then we had a distribution of boarding day schools. And as you can see, Homa Bay and Kajiado schools were largely boarding schools. Nairobi schools was almost equally distributed. And then we selected schools from each of those strata. And so I just wanted to highlight that some of the schools, particularly the ones in Kajiado, were in very remote places, and they could only be accessed via motorbike. And this is one of our staff members, Florence, and she had to travel to these very dusty places to get to these schools. And I just want to highlight her spirit. She said that if some kids go there, then if kids are going there to school, then there must be a way that I can also get there. And she really made an effort to try and get to as many schools as she could. However, some of the Kajiado sites were quite costly to go to. Those border rides were quite expensive, and they were really hitting on our travel budget. And so it became difficult to access all the Kajiado schools. So we ended up with a final survey of 36 schools in Homa Bay, 39 in Nairobi, and 25 schools in Kajiado. So I think this is something that we all are aware of, the background of the school structure in Kenya. We have national, extra-county, county, and sub-county schools. And we know that the county and sub-county schools will largely serve youth coming from within the local communities in most cases, while the national and extra-county schools will serve bigger populations. And so when we look at the school distribution and by type, this was when we had done 97. We recently just completed the interview, so now we have all 100 done, but we ended up with 5 national schools. 100% of them were boarding, and 80% of them were same-sex schools. And then as you go down the list, you see a similar pattern with the extra-county schools, but as you come down to the sub-county schools, majority of them were same-sex schools, few of them were boarding, and few of them were boarding, and few of them were same-sex. So we see a different distribution than we see for these other schools, which is something I think we all expect. And then when we go on to the characteristics of the schools themselves, the median school population was 400, and they were higher. The population was high in Nairobi compared to the other counties. And then 60% of the schools had boarding facilities. The student staff ratio was 13. And again, this was significantly higher in Nairobi compared to the other counties. And then 25% or 24 of the schools had a staff who was dedicated to health. These schools were all boarding schools. And in some of the schools, most of the schools, it was a nurse. Some of the schools had nurse aid or matron, and others had a clinical officer. These were some of the schools that actually had a clinic that runs within the school that serves both the school, that largely serves the school community. And so there was a clinical officer in that school. And then 98% of the schools had guidance and counseling staff. And just in case you're not aware of this history, this guidance and counseling department was actually recommended by the Ministry of Education to deal with educational and vocational guidance and psychosocial counseling in schools. This was way back in the 80s, and it was in response to major sexual violence and arson incidents that occurred in schools. However, there's a really nice paper by Grace Wambu that reviews this guidance and counseling departments. And what they identify is that usually the guidance and counseling staff is a teacher who has to perform regular teaching activities in addition to guidance and counseling. And there isn't a standard curriculum on this outside the normal teacher's curriculum that includes counseling. So I think there are opportunities to improve the guidance and counseling departments in the school by thinking about what is some form of standardized training that they could all get so that they can be able to support students better. And then when we move on to health training, and these were the key things we were looking at, we asked schools whether they had somebody who was trained in any of these topics. And we asked whether there's anyone, and then we also asked how many people had been trained. And so what we see overall is that a good number of the schools had staff trained in counseling, which could be aligned to their training curriculum, or it could be they had additional training in counseling. We didn't collect quality of that counseling course, which is something that we will do in the future. But then when we look at the HIV-related topics, very few of them had training in any of these topics: HIV care and treatment, which you'd expect particularly for boarding schools, mental health, stigma reduction, prevention, confidentiality, and psychosocial support. So I'll go through each of these training and try and see whether there were some differences based on the county and also based on whether the school was day and boarding. So when we look at care and treatment, and this is really important for adherence, we looked to see if there were differences in training, and we found that there were county differences. More staff trained on HIV prevention and care in Nairobi schools compared to Kajiado schools. Quite a number of Homa Bay schools were also trained. I think this is efforts related to what Elizabeth Glazer Pediatric AIDS Foundation is doing, the EGPAF team, and then we had significantly higher training in boarding schools compared to day schools. And then next we looked at confidentiality. So confidentiality, we asked them whether there was someone in the school who has been trained in confidentiality. And again, Homa Bay schools, 91% of the schools in Homa Bay reported that they did have somebody trained in confidentiality. And I think probably related to high prevalence, but also probably related to the Red Carpet program and other programs ongoing that have really supported training for these HIV-related topics. And we had much lower training in Nairobi or Kajiado schools, no differences by day or boarding school. And then again, for stigma reduction, lots of training in the Nairobi and Homa Bay schools, still not quite that much. Homa Bay was 43%, Nairobi 47%, but pretty low in Kajiado schools. And then for psychosocial support, we see the same pattern, higher in Nairobi and Homa Bay, lower in Kajiado. And then there was a trend higher for those in boarding school, for boarding schools compared to day schools. And then mental health, I think this is another emerging topic of concern given the current issues ongoing in schools, and also the focus on mental health in the youth, that we had higher training, higher staff trained in mental health in Nairobi, 62%, and Homa Bay, even though that proportion is still quite low compared to Kajiado schools, where none of the schools we interviewed had somebody trained in mental health. And then again, in counseling, we see the same pattern. So overall, we can conclude that there's low training for many HIV-related topics in the schools that were surveyed. We did see regional differences with higher staff training for Nairobi schools. And then we also saw higher training in boarding schools for HIV care and prevention and psychosocial support, which is what we would expect because the kids are spending a lot of time there. And then we asked about school resources, and we asked whether they had a designated clinic room or space that could potentially be a place where people keep medicine or a safe space to take medicine. A majority of the schools did not have a designated clinic space or room for medical procedures. And then the Nairobi schools, I guess the resources, because of resources, tended to be the schools that had more of these resources compared to the Homa Bay and Kajiado schools. And then there were also more schools that reported having space in the boarding schools compared to those in day school. And then we also asked them whether they had a confidentiality policy, and we know that confidentiality is critical, particularly for HIV, and training in this may help parents or youth disclose their HIV status and facilitate support. However, only half of the schools had a policy, and most of the policy was around who handles youth with chronic illness. So they would say like one person, or like this information is only known by 2 people, but it didn't really address what to do to ensure confidentiality or what to do when confidentiality was breached. There were significant differences by counties, and as you see, Homa Bay seems to have really worked on confidentiality, likely because of the high prevalence, and I say there are other efforts going on. And then despite that, 88% of the schools required that any chronic illness be reported to the school. So, and this wasn't different for boarding or day schools. So a little bit higher in boarding schools, 91%, but not significantly different. And then where meds were stored by the school, we also asked about medication use and how they required that medicine is used in the facilities, and we asked whether there was a policy for medication use, and 48 or 49% of the schools said there was a policy. This tended to be more in the boarding schools, which makes sense because kids who are in boarding schools are the ones who are likely to take their medicine in boarding schools. Day schoolers sometimes they can operate from home where they take their medicines in the morning and in the evenings, and they don't have to really carry medicine to school. And then when we asked about medication storage, majority of the schools that had a policy required that the school stores the medicine. Some of them required, some of them said, okay, they can store themselves, but it's mostly day schools. And some had an option where the school or the individual could store the medicine. We saw that, I think I've mentioned, the policy availability was higher in boarding school. Then when we look at differences by medication storage requirements, and this is, I think, what we would expect, for the day schools, most of them required that people store the medicine themselves, because I guess it was one dose, maybe very little, long-term storage to just be what they're taking for the day. But then the boarding schools required that the school stores the medicine. And then we asked about whether they had policies for clinic attendance. And I guess these questions were all aligned to the gaps that we saw as we started initially. And what we saw was that, again, Homa-based schools were more likely to have a policy on clinic visits. 35 of the schools, 100% of the schools had a policy on clinic visits. And boarding schools were more likely to keep a schedule of the clinic visits. Then we asked questions around rescheduling exams, because this was another thing that adolescents really talked about, that the school will not agree to reschedule an exam if it falls on a clinic, if it falls on a clinic day. So they would sometimes say, I missed my clinic because I had to do an exam, and we specifically asked that question. And 62 of the schools said that they can reschedule exams if they occur on a clinic visit or give another exam to the child. And when we look at that policy, it was mostly more likely to happen in, again, the Homa-based schools compared to the schools in Nairobi or compared to the schools in Kajiado. And you can see that difference there. And then we asked schools whether they have some stigma reduction activities that were going on in the schools, or activities that were considered to be stigma reducing. And a lot of them talked about educational activities and sports. And the way educational activities were considered as stigma reduction activities was that somebody would come and talk about HIV, and they would talk about it and give the correct information, and therefore use that education to reduce stigma. For sports, it was a little different. They talked about sports being all inclusive of everyone who has, whether they have HIV or they don't, whether they have whatever illness they had, then they would still be included in sporting activities. So again, I think with the sports, there might be some room to think about how sporting activities could actually be supported to improve stigma, to reduce stigma, sorry. And then there was this concept called the school families, and this was something we saw in the Kajiado schools. So a lot of the Kajiado schools talked about having the staff members supporting a specific number of students. So they would divide up all the students to different staff, and then they would meet together and kind of have talk like a family. And so within that little group, then they would talk about the challenges they're facing, and sometimes issues around stigma would come up in those groups, which I thought was really interesting. And we didn't hear about these school families in any of the other counties. And then we asked teachers what they thought were the biggest challenges. And they talked about, a lot of things, but I tried to pull out the frequency by which these issues were mentioned. And a lot of them talked about health resources, a lot of them, and these health resources were mainly around like accessing clinics around, and having a space in the clinic that could be used to store medicine and things like that. And then there were a lot of talk about non-adherence and how to monitor who's taking medicine and who's not. Non-disclosure was a big issue, because then if there was non-disclosure, the school doesn't know the adolescent is taking medicine, then they cannot help with monitoring, they cannot help with adherence. They talked about stigma, they talked about poverty and family issues also being important issues. So just to summarize the findings from the survey, we found low prevalence of HIV-related training in the schools surveyed. Most of the schools required disclosure of chronic illness, but few had policies for medication use, confidentiality, or clinic attendance. We did see those county and school type differences in approach. And then we saw that stigma reduction activities were largely educational or sports, and non-adherence and disclosure in school resources for health were the biggest challenge to care. So in conclusion, there are opportunities for training and strengthening approaches to youth support. You've seen the large populations, the large school populations that I showed at the beginning, where you have a median student population of about 700, which is quite a large number of youth who can be reached in the school environment. But we saw that there were few trained staff, and the good thing is that there are already these stigma reduction activities that are incorporated in the school environment. And so some of those could be leveraged to more systematically address stigma-related issues. I think there are opportunities for cross-county learning. I think Homa Bay could support, Nairobi, or could support Kajiado to really learn about some of the things that they've put forward. And then lastly, if we equip schools to better support youth, we may be able to address some of the non-disclosure and adherence challenges that teachers mentioned as some of the biggest barriers to supporting youth better. So I'll just pivot a little bit and just highlight some of the qualitative work we're doing and some of the things that we've been able to identify. And this is mostly aligning to what we found in the school surveys. We have done some interviews with adolescents and also with caregivers, and adolescents are telling us that it's difficult to take medicine for fear of stigma. Like this adolescent, reflecting on her experience taking medicine in boarding school, she says it's hard to take every day. Sometimes I missed and I was afraid that others would see me. And then this fear of stigma drives non-disclosure of HIV status to schools that could impact clinic attendance. And this adolescent in day school who had not disclosed his HIV status to the school, while reflecting on his experience getting permission to attend clinic, said, sometimes the teacher does not trust you're sick, and the teacher may think that you just want to miss a class. So we've also talked to caregivers, and what we see is that both adolescents and caregivers recognize that disclosure is essential for support, but they require a trusted school staff. Like this caregiver of an adolescent transitioning to boarding in the next year who said, I plan and I hope to get a teacher I can be free with and disclose about my daughter's status, so that in case of anything, this teacher can be there to offer assistance. So you're saying we're seeing this is really aligning to exactly what is happening in the schools as we've seen in the survey. And just to highlight that Helen Mora is leading the qualitative work and doing a really good job with these youth interviews. And then this is work from the adolescent surveys. We are also doing some surveys with adolescents who are enrolling from the clinics, and we are asking them about their school experiences. And Brenda Wandika, she's a current MPH student at the University of Washington, is going to be using this data for her MPH thesis. And we're already seeing from these survey results among adolescents, these are adolescents at a median age of 17, and 89% of them are in school, 33% of them have been in a boarding school. And we already see differences with missing ART in boarding school, where you see 41% of them say, yes, when I was in boarding school, I did miss my medicine, compared to 23% of those in day schools. And then disclosure, we see again big differences here, disclosure in boarding school and disclosure in day school, 77% and 37%. So we're already starting to see some differences there by school type. And again, very low support for ART use. We asked the youth, these are youth who are attending clinics, whether their school supports ART use. Like, is there anything that the school does to support ART use? And very few of them responded yes to that question. And while we saw that 79% of the schools reported they had a counselor, and this is not a 79% may not be a representative of the whole country where these kids are coming from, but only 42% of the youth said that their school has a counselor. So even that counseling role might not be available to all the kids in the school environment. So the next steps is we have targets for year 2. We want to complete the qualitative data analysis, complete the survey. We want to complete enrollment for that. The youth surveys I've just mentioned, we have currently enrolled 630 youth. Our target was 880. And then we're planning to begin planning work for year 3 and 4. This is the stakeholder interviews and the stakeholder work. And then we've also been able to submit new grants that are aligned to this study. So Professor Wamalwa is PI of a recently submitted Stigma grant, and this looks at a multi-level approach to reducing stigma among youth living with HIV. And we're going to be identifying barriers and facilitators to implementation of those guidelines that we looked at. And we're also planning other grants, particularly around mental health, aligned to this work and to the gaps that we have already seen that. And then, as I said, the ultimate goal of the K43 award is to finally be able to independently write my own bigger study that is that I should begin writing in 2023. So I'd like to thank you all for listening, and I just want to acknowledge all the partners. I haven't done this work alone. It's a big team of people who are involved, and big team of people who have partnered together, and for the funding from the National Institutes of Health. So thank you, and I'm happy to take comments, questions, suggestions.
Thank you very much, Irene, for this, for sharing with us this information. It's been a really informative session, and this is really important work that is going on, and it's just exciting to see even the results that are coming in from that, from the surveys and what the youth are saying, and all these barriers to their treatment and for optimization of the HIV treatment and outcomes in schools. Maybe we'll start off for our participants. You can comment in the Q&A section, ask your question. We have here someone says, very good and relevant study that will inform policy by both ministries of health and education for the benefit of the infected and affected students and families. I couldn't agree more. From Nusim Bogo, Hongera, excellent work. I think it's important for the clinicians to be encouraged to give clinic appointments. Stigma. Yeah, that's a very important input, as you saw from the study, that sometimes they miss the clinic dates, especially when it falls during the exam days. What I saw was a lot of stigma. There was a lot of mention of the stigma and how this stigma is reducing there's a lot of stigma in relation to HIV in schools. And maybe, Irene, you can just give an overview of some of the ideas that you have towards working to reduce stigma in schools, apart from what was mentioned in the study that they use the games. Maybe add other views to reduce stigma.
Yeah, that's a really important question, and I think it will definitely be one of the biggest item in terms of thinking about interventions for youth. So when you look at the literature and try to understand what kind of stigma interventions are available out there, and what are the kind of things that work, a lot of the literature talks about education being one pillar, and then contact with positives being another pillar. So you want to educate people and give them the correct information, but then you also want to create an environment where you have some contact between people who are HIV positive and who are not, and where they can share life experience and people really see life from the perspective of the other person. I think thinking about how that would work in a school environment can be challenging because you don't want to stigmatize anyone, you don't want to inadvertently disclose, but I think there are ways that we could think about implementing some of these activities. But that's a really good question.
Yeah, sure. Thanks for that. I request there's some who have raised their hands. I request that you can be able, if you can be able to unmute, if you can be able to maybe promote them to panelists. And on the chat box, we have Violet Makoha saying very vital information, especially as we strategize to achieve the 95-95-95 goal. Thank you for Avery. Yeah, that is very true. Let me see.
I think Elizabeth Omori has a question. Go ahead, Elizabeth.
Okay. Helen Ongori, maybe you can mute her. Maybe it was by mistake. Dr. Thomas Ogara. I'm not sure why we are not able to hear. Comments here, great work, Dr. Irene. Thanks, Dr. Kutui, for that. From Bonnie, it was awesome. This will help. Thanks, Dr. for that wonderful presentation and eye opener. From Dr. Kizito Lubano, excellent timely study. Congratulations, very informative presentation. Very great work. And thoughts considering the rising numbers of newly diagnosed. Yeah, that's very true. And especially we've been trying to reach the adolescents adolescents in the HIV care, and especially where we can be able to have, I'm looking for this word, integrative care. I don't know how we can be able to integrate what we are doing in the schools and the healthcare, so that we have like a continuous system, because currently we have what we are doing in the health system, in the healthcare. They're coming to the clinics, the health centers, but it seems disintegrated from the school system. And maybe Irene, you can mention a comment on that, on how best you can be able to put these two together, how you see that in the future, maybe.
Sorry, I think you keep breaking. Do you want to repeat that?
Sorry for that. I don't know if you're able to hear me now.
Yes.
Yes, I was asking, there's been very many comments here that this is good work. And what I was wondering is how can we be able to integrate it even to the healthcare system? What we have currently is somehow disintegrated. We have care in the health system, the clinics, but the adolescents are in the schools. I don't know how you can be able to join those two together, how you see it maybe in the future or in future work with the adolescents. I'll comment on that, yeah.
Okay, that's a good question. I think one of the things that and Judith Kose has shared a paper that they've recently published in PLOS ONE that's around this topic. I think it would be very nice for you to look at that paper. But one of the things that the EGPAF team promotes is that the schools have a tight link with a clinic in that community, because in that way, then the clinic and the school can work together to achieve some goals. The clinic can support training, the clinic can support care. And I think with the NHIF program for high school students, I'm forgetting the name, is it called? Forgetting the name of that program, but with that program where they're actually providing NHIF services for anybody who's in high school, I think there's a way that brings the clinic closer to the school, because these kids will likely be seen in the surrounding clinics. So if you build a stronger collaboration with the clinic, then, and that's actually already advocated for in the guidelines, the thing is just how do you do it? How do you help the schools and the clinic work closely together? That way, then you can be able to bring health in the schools. And I think it's not just HIV. I think we have to think about kids who have diabetes. We have to think about kids who have sickle cell disease, because these are kids who nobody hears about, but they are also in schools. So finding a way that all these children with chronic illness can be able to still attend their clinic and be in school, and the clinic and school work together, and also making sure that these kids actually have the best opportunity in life. We shouldn't restrict them because they have this and that. So I think there's a big thing to really figure out how we can bring this together. And I see these comments about MOE and MOH collaboration, which is really important. But identifying who the right person is, if anybody has ideas about that, I would really be glad to hear them, because the link with the MOH with the MOE, given all the changes that happen, is a little bit tough. But I take those points to heart. That's really nice. And then I'm just going to go over some of the questions that I'm seeing here. Is there a HIV policy in the Ministry of Education that will enable any interventions planned? It's a really nice question, Penina. And there is a guideline that was developed by the Ministry of Health, not the Ministry of Education. I'm not quite sure who the partners were from the Ministry of Education when the guideline was developed, but there is a gap in bringing those ministries closer and working together to make something that will work. And then there's any arrangement for feedback on the study to the school managers? Yes. So the second phase of the study is to take all this data back to the schools. So the plan is that we will work with the school managers to tell them, this is what we found, and we're already identifying, as we go around, we're identifying some of the people in the schools who can support us to even think about the intervention. Whatever we develop, we're hoping we can develop it with the input of all the stakeholders. So we will involve as many schools as possible in this study.
Thank you for that. Yeah, there's one more up there, The Adolescents by Mohamed Musoke.
So this one on South Africa has been working on similar issues. They have a school health team that became a link between MOE and MOH. South Africa has actually been doing a lot of work in the schools, and there is a lot of stuff we can borrow from that group. So thank you for the comment. So then I'm going to go to the chat. I think it's hard to move to the question and answer and then the chat box, and I'll just try and highlight where there are questions. So Maurice is talking about it would be a great idea to help schools stock self-testing HIV kits. I think that's a very good idea, but very controversial. And I think we have a long way to figure out what is the best way to work with schools and what's the best way to access them. South Africa has done some of this work, but then the permissions they could get were outside the school hours. So if you do something that's outside the school hours, then what happens is that your participation becomes very low because you're selecting for a certain group of people who will agree to come to after school activities. So we need to find a way to be more integrative so that the school and the clinic work together for the common goal, which is the adolescent health. Then Diana says creating a support system for learners will go along with helping us improve viral suppression. I agree, we've talked about the collaborations. Okay, then Kidega asks did you find out if the nearby health facilities could do follow-ups in the schools on psychosocial issues? We did ask, and what's the role of the nearby health facility? We've talked a little bit about that, and we did ask whether they are linked to a nearby clinic, but then again, the quality of that link, we didn't ask that. So we asked, why are you linked to a nearby clinic? But I think there are a lot of questions around what is the quality of that linkage and how can that linkage be improved? And then I think we've talked about the suboptimal viral suppression in adolescent. Mohamed Musoke, I take that comment. How do you think schools can help in mitigating the social factors behind the poor viral load suppression in schools? I think the schools can have some structures. We can create some structures in the school that could support some of these things. And I think this isn't something that's unique to HIV. I think the WHO had a guideline in the 80s that talked about schools being supportive environments. Schools have been places where people get, deworming therapy and other kinds of community-based programs have been implemented in schools, including food programs and all that. So I think there are ways that we could help work with the school environment to improve outcomes. And then there's a question, many hospitals are required to create and have nicely managed youth-friendly section to accommodate youth. This must be encouraged by policymakers, school admins, and students. I agree with that comment. how can we fight stigma in school? That's a big question. I think that's the elephant in the box. We need to figure out a way to do that. I don't know if I've missed any other.
I think that we have answered most and a lot of comments. Thank you so much, our participants, for keeping the comments. There was a link that was shared in the chat box. I'm actually trying to, yes, by Judith Kose. Thanks, Dr. Njunguna, for a great overview of the great work. Folks, see here, there's a link to our study that Irene alluded to. It was just published in Close On, so there's a link there. And I don't seem to see any other questions. A comment here, quite insightful session. And as for those given TCA during exam time, clinicians should and must know the school program so that we tie the TCAs to be during school holidays. Sure. So a lot of input there, and how to just make it more patient-centered and centered to the adolescents to make them be able to access their medication and to go to their clinics. I think that's
just a comment on that one. I think for the TCAs and what we've noticed when we talk to adolescents is that the TCAs are given to coincide with holidays for the youth who are in boarding school, but not for the youth who are in day school. I think maybe this is something that in the future could potentially change, because even the youth who are in day school sometimes have things they need to do in school on the weekends. And there are kids who've talked about, I needed to go to clinic on a Saturday, but the school said that I needed to do something. And so that conflicts with them. And also the schedules, some of the kids in day school have to, do a bit more schedules than the ones in boarding school. So I think just harmonizing the approach for all youth could be helpful.
Yeah, thank you, Dr. Irene. I wanted to find out what would you say would be your policy recommendations? And were you considering doing like a policy draft to communicate these very important findings with the Ministry of Education and the Ministry of Health?
That's a really good question, Dr. Kinuthia. And so what we had envisioned is that at the end of our year 2 or somewhere in the beginning of year 3, we would be able to have a comprehensive summary of the school survey, the youth interviews, and then the adolescent surveys, and then we can use that data to think about the next steps. And the next steps would be working with policymakers to develop, some interventions that would work. So we are headed in that direction. I think maybe the pace is a little different, and getting the partners to support us is definitely something that we really need to think about. I had not thought about making a policy document, but I think that's a really an excellent point. And I think if because this group is quite large and diverse, if there are people who have links to Ministry of Education, people who might be interested in this work, I would really be glad to be linked to them.
Definitely, I'll link you up with them, because we have done some work with them, and I'm sure they will be very interested on this. And also the research department in the Ministry of Health, who will be very interested to see what they can pick as a policy recommendation. We can continue with this conversation.
Thank you.
Thank you for that, Irene. Maybe there's one more here. Are there measures to integrate the prevention of spread of HIV among adolescents, like use and distribution of condoms in schools?
It's a really tough question, that
Yeah.
I was hoping not to get into. But I think we all know the debate out there. Sexual and reproductive health in the schools is a very difficult topic. And I mean, I think it's important, but how then do we package it for us as healthcare workers? How do we package it in a way that other people find is useful and is helpful? I think how to package is a big problem. Maybe starting off with treatment, because for children who are already on treatment, it's really not controversial. Maybe that could be our entry point. But I wonder whether some of the people who do more prevention work, Dr. Kinuthia, I know you do a lot of prevention work, whether you would want to make a comment on this, or maybe Dr. Kose, I don't know if you're doing any prevention work in EGPAF, because I think that's a really thorny topic.
Dr. Kose, you wanted to comment? Yes, I can say from our side, we have really not addressed the issues of condoms in our work. In our prevention, currently we are focused more on pre-exposure prophylaxis, but the issues you have raised, especially the ministry's perspective about age of consent for sex, which should be above 18 years and above, obviously brings some challenges in terms of thinking about how to roll out those kind of programs. And I think probably what we need to do is to have more engagement with the ministry and the policymakers from the ministry in terms of how do we protect the youth, even with the current scenarios where we are able to see there are still risks, but at the same time, we are trying to be true to the policies which are being aligned. So I think it's a bit of a tricky balancing act.
Yeah.
Yes, sure. Okay, now that we come towards the end of this session, I'm not saying any more open, and we really want to thank you, Dr. Irene Njunguna, for this presentation and for this work. It's really important work, and just as we have mentioned, it will be important here to go forth with it, and we see how these things can be implemented for the sake of our adolescents' health, and to just prevent HIV and to take this information further. So we really thank you, and we will welcome you again, even as you continue with the studies and more results come in. These are exciting results to just share with us your findings, and we still discuss more on this work. And yeah, it's good knowledge, and it's really good. I'm really excited myself to have this talk. So we've come to the end of this session. Do have a lovely evening. Let's join in the next week. So goodbye to everyone. Do have a lovely evening. Bye.